stable coronary artery disease. We're asking Dr. Rehal to come back up. He's got what I know you'll find a spectacular talk in terms of revascularization, because that's kind of very, very controversial at times, and he'll, again, simplify this for you. But in terms of the pretest, let's talk about the 67-year-old man with class 3 angina on medical therapy. You have an exercise test, 6-minute duration, 2-millimeter horizontal ST depression. Resolved after 5 minutes, 1 sublingual nitroglycerin. The ischemic threshold, in other words, the heart rate at which he developed his ischemia, was 90 beats per minute. Cardiac cath is performed, reveals normal LV function, a calcified 90% mid-LAD lesion. You would go ahead and do a PCI for A, prevention of myocardial infarction, prevention of heart failure, prolongation of life, or improvement of symptoms. And let's quickly get this one. Okay, Dr. Rehal. Let's go on to the next one. 65-year-old man, new onset angina. Comorbidities include type 2 diabetes on metformin and hypertension. Angiography shows 3-vessel disease with mildly reduced LV function. Okay, the treatment of choice is, and you can see this coronary angiogram which shows where the lesions are in the RAO caudal view, the LAO, and the right coronary artery. Medical therapy, multi-vessel PTCA, multi-vessel stenting, cabbage surgery. Depends on the comfort level and the availability of the surgeon or interventionist. The interventionalists are always comfortable, right? 94%. Okay, a previously healthy 53-year-old man presents with angina. What are the key prognostic indicators? LV function, extent of CAD, degree of ischemia, or all of the above? Okay, let's see the answer. 86%. You'll talk about this, and you'll talk about that. So, again, bring Dr. Rehal to the stage, talking to you about revascularization strategies. Take it away, Chet.
Yes, thank you very much. Let's continue on with bread and butter cardiology. This is decision-making for revascularization in stable ischemic heart disease. Again, I'm going to emphasize stable ischemic heart disease, not talking about STEMI, not talking about ACS or non-STEMIs, all right? So, learning objective number 1, recognize the indications for revascularization in patients with stable coronary disease, understand the principles to guide these revascularization decisions, including FFR, which we'll talk about towards the end of the talk. Objective number 2, compare the risks and benefits of PCI versus bypass surgery versus medical therapy, and use this information. And we'll talk extensively about this. 3, recognize the indications for revascularization in diabetic patients with coronary disease and select the appropriate intervention. Again, we'll talk extensively about this. So, revascularization, I think, is a very, very important topic clinically, for board exams, and societally as well. Coronary disease is amongst the leading causes of death in North America and Western Europe, and it's rapidly catching up in the rest of the world, particularly Eastern Europe, where there's an epidemic, the Far East and South Asia, where there's another epidemic. In the US, there are at least 7 million people with overt coronary disease, probably a couple million others as well, up to 2 million procedures performed annually, whether it's stenting, bypass surgery, etc. And it makes for great board questions. So what do you need to know for the boards and frankly for clinical practice? You need to know the indications, the safety, and the efficacy of the revascularization procedures and modalities that we have. You need to know clinical management, including adjunctive therapy and recognition of complications, and the guidelines. In particular, you need to know the class 1s and the class 3s. These are the do's and the don'ts. You don't have to get too hung up on what's a class 2A, class 2B, the kind of controversial areas, but you really need to understand the class 1 and class 3 guideline indications. What don't you need to know for board examinations? You really don't need to know the arcane details of the latest trials. You don't need to know the latest abstracts and the latest controversies at the ESC meeting, which is going on right now. That's not relevant to the board exams. You do not need to know investigational devices at all. Marketing claims, cath lab legends, all right? So it doesn't matter what your local, catheterizers would do. That's not really relevant for the boards. So stay focused on the guidelines and the evidence, the class 1 and class 3, and you're going to do just fine in the board exams. What we're going to talk about in the next 25, 30 minutes, the indications. We'll talk about bypass versus medicines, BTCA or balloon angioplasty, which was the groundwork. We'll give you a little historical perspective. We'll talk about stents, touch on diabetes again, drug-eluting stents, multivessel disease, and left main disease. Now, there's again, just like for medical therapy, there's a huge, voluminous literature around all of these topics. What I'm going to try to do is to give you a framework that you can carry with you into your clinical practice and into the boards, and use this framework to integrate new data as they become available. So I want to go back to what are the imperatives in stable coronary disease, okay? What are the indications? There's only 3 indications, only 3. One is to improve symptoms, to make your patient feel better. If you can't make your patient feel better, you better ask yourself, why am I recommending a revascularization procedure? And the answers may be to improve long-term survival, and that's really a very small subset. And 3, to potentially decrease the incidence of non-fatal endpoints such as MI, heart failure, and ventricular arrhythmia, okay? Of these 3 indications, what 2 does revascularization work for? It's only these 2, okay? So revascularization can definitely improve angina, and for some patients, it can improve long-term survival. There's no revascularization procedure that I know of that can yet do this, that can reduce MI, heart failure, or arrhythmias, right? So keep that in mind. So what does reduce MI and heart failure? It's medical therapy. So this 3rd indication, keep my remarks in my first lecture in mind, right? So these are the only 2 indications right now for revascularization. So let's think about bypass surgery in that context. The randomized trials are small and few in number that underpin our current practice of bypass surgery. These were the original studies performed, the VA study, the European study, the coronary artery surgery study that we at Mayo participated in, and a few smaller ones. Look at the sizes of these studies. These were done in the 1970s, 1980s, and they're very, very small studies. But that's all we have right now. So this is an important curve that Dr. Youssef published in 1994. He pooled all of these studies together, found 2,649 patients, and published this important curve that showed that patients treated surgically, okay, with stable ischemic heart disease actually did better than those treated medically, but that by year 10, the mortality rates caught up. And interestingly and importantly, early on, patients treated surgically had higher mortality than those treated medically. So keep this in mind. There's a risk up front to do any surgical procedure, so patients must live long enough, typically 2 or 3 years, to accrue the downstream benefits, okay? So what this means is if somebody has metastatic cancer and their prognosis is less than 2 years regardless, you should not be recommending bypass surgery, right? What this also means is if somebody needs a non-cardiac surgery and you think you're going to reduce their risk by doing bypass surgery pre-op, you may actually be increasing it. So you have to keep in mind the interplay of risks and benefits. The benefits are downstream and after 2 or 3 years. So that's point number 1. Point number 2 is that these data were very important in understanding which subsets of patients actually benefit. So if you look at patients with 1 vessel, 2 vessel, 3 vessel, or left main artery disease, it's really only patients with 3 vessel and left main coronary disease that had a survival benefit, okay? So this is really important. Board exams, class 1 indication for bypass surgery is 3 vessel disease and left main artery disease, okay? Class 1. For 1 vessel and 2 vessel, you may still want to recommend bypass surgery if there's no other means of improving their symptoms, but you would not do it for prognosis. These are the only 2 subsets in which you would recommend this for prognosis. Now, the other interesting thing was that patients both with normal and with abnormal LV function benefited, but the patients that have abnormal LV function, their absolute risk is higher, so they get more absolute benefit. And if you notice here, it was only patients that had abnormal stress tests that actually had a survival benefit. So if they didn't have an abnormal stress test, they had no survival benefit. Now, what Dr. Yusuf and his colleagues did is they put all of these groups together and determined 3 tertiles of risk. Low risk, which is about 1% per year of death. That's about as low as we can get it in coronary disease. A middle risk, 14 or 15% mortality at 5 years, that's 2 or 3% per year. And a high risk group where the risk is about 25% after 5 years, or about 5% per year. That's what we consider high risk in coronary disease. And if you look here to the right, if your patient is in the high risk group, okay, if they've got low LV function, if they've got 3 vessel disease, and they have class 3 angina, that's high risk. That patient has about a 50% improvement in the odds of dying with bypass surgery. So that's clearly indicated. So in other words, the sickest patients and the highest risk patients derive the most benefit. Conversely, low risk patients, 1 vessel disease, normal LV function, do not get a survival benefit, and you should not be recommending bypass surgery for them, okay? So think about this risk-based approach. I think any one of us here can easily and quickly categorize patients into low, medium, or high risk based on their clinical presentation, coronary anatomy, and LV function. So as I've mentioned now a couple of times, you need to know the class 1 indications for bypass surgery include left main disease, 3 vessel disease, and a couple of other ones here, 2 vessel with proximal LAD, maybe after cardiac arrest, and simply for symptom control if you can't do it with PCI and medications. Class 3, what you should not do is a low-risk patient with mild angina. There are some important limitations of these older data, though, that I want to point out to you. And the reason I'm pointing this out to you is to promote the concept that we need new and more modern data. So, unfortunately, in the CAST study that was performed here in the US, bypass surgery did not prolong life or prevent MI, okay? So it does not prevent MI. And in the VA study, they were able to document that the benefits were limited by graft closure. So remember, this was largely vein grafts that were used, and the problem with vein grafts is they get arterialized and then develop aggressive atherosclerosis. And you all know this. You've seen many angiograms, I'm sure, on patients with vein grafts. A couple of other important limitations that people sometimes aren't aware of is that there was hardly any patients over the age of 60, only 7%, okay? The median age of patients that we sent to bypass surgery is about 70 now. That's the median age. And there were no women. So this is males, and 96.8% were male. You ever sent a woman for elective bypass surgery? Yeah, there's no data. And so it really speaks to the fact that we need to update these trials. And by the way, the left main artery disease was also a relatively small proportion, just 6%. Now, the good news is bypass surgery has not remained static, and new conduits and new surgical techniques have improved the outcomes of patients. So for example, total arterial bypass surgery affords much better long-term outcomes than venous bypass grafts or even a single lima graft. Off-bump bypass surgery continues to improve. This is controversial. I doubt that you'll get asked on your board exams. You know, the literature that's coming out goes back and forth on this. And the STITCH trial, which you're all familiar with, enrolled 1,212 patients with severe LV dysfunction, randomized into medical therapy or bypass surgery. Unfortunately, it wasn't until very late follow-up that they were able to show there might be a potential benefit. So this trial really didn't provide strong evidence that we should be revascularizing patients to, quote, improve LV function or just to prevent sudden death in patients with severe LV dysfunction. I'm not going to get into the whole viability concept, because what the trial showed is that patients who had viable myocardium actually did worse. So it's still very controversial, and I don't think you're going to see that in your board exams. So that's bypass surgery. Important treatment. You need to know the class 1 and the class 3. Data are old and need to be updated. Next, what about balloon angioplasty? So this is a typical coronary balloon. And when I trained, this is all we had. We just had balloon angioplasty. The problem with it was twofold. One is that restenosis rates were high. 30 to 40% of patients would come back. And even more importantly, emergency bypass rates were up to 5%. So every week we were sending a patient to surgery. Now, having said that, despite all of those things, it did work in selected patients. So this is the first coronary angioplasty in 1977 that Dr. Grunzig did intraoperatively, and you can see that he dilated the proximal LED and it looked good. Here's another patient that Dr. Grunzig, who invented this, did. 24-year follow-up after 1978, multivessel PCI, and all the sites looked nice and open. So balloon angioplasty has significant limitations, but in selected patients did provide good long-term outcomes, and because of that, the field continued to develop. Now, what do we need to know? I think the COURAGE trial is an important landmark trial in cardiology, where patients with stable disease had either optimal medical therapy or optimal medical therapy plus PCI. And as you all are aware, the PCI as an initial management strategy did not reduce the risks of death or MI or other cardiovascular complications. So you can see the rates here. Patients with optimal medical therapy actually did better than the ones who had PCI initially. So what we took away from this study is that the indications for PCI really are symptoms. You don't do PCI routinely or in a preventive manner. It's only for symptoms. An important observation, though, in the nuclear sub-study was that the degree of residual myocardial ischemia predicted future events. So, for example, if greater than 10% of the myocardium was ischemic, then the event-free survival was actually fairly low. It was only 60% at 5 years. So this now has generated a hypothesis that we should be performing revascularization on the basis of ischemia. It's being tested in a trial called ischemia that's funded by the NIH. This is probably not going to show up on the boards, other than you need to be aware that myocardial ischemia is an important and critical prognostic finding in patients with coronary artery disease. So conclusions from the COURAGE trial: PCI does not improve rates of death or MI when used initially. 2, optimal medical therapy is indicated for all patients with coronary disease, just like I described in my first lecture this morning. PCI and OMT are complementary. They're not either or, okay? And the ischemia hypothesis we just talked about. So that's balloon angioplasty. What about stents, particularly bare metal stents that were the first ones? So bare metal stents are essentially endovascular scaffolds. Almost all the PCI cases we perform nowadays, we're using some sort of stent. And the reason that bare metal stents really caught on quickly is that we got better acute and chronic angiographic results. The target lesion revascularization, or the redo rates, fell to 10 to 15%. But this was the key. The emergency bypass rates fell to less than 1%. And those of you that were around in this era when the first stents came out will probably recall the first couple of cases where you put a stent in to treat acute dissection. I mean, it really was like magic compared to what we had before, where patients had to go to emergency surgery. And in our laboratory, this was a paper we published in 2005, the advent of coronary stents reduced the risk of emergency bypass from about 9% down to 0.3%. So stents made PCI very safe and very translatable to all sites. There's been a number of studies that have looked at stents versus medications, and they all basically showed the same thing, which is that death or mortality rates are not improved by stenting, okay? And in fact, either are non-fatal MI rates in the future. So stents made PCI more applicable and safer, but they did not reduce rates of death or MI in the future. Now, the one good news for PCI, though, is that in comparison to medical therapy, it's more powerful in relieving angina in almost all of the studies that have looked at this. So keep this in mind in terms of indications. Remember, the first and the best indication is to make your patient feel better. That's a good indication. PCI works in terms of making your patients feel better. There's no evidence that it really improves long-term survival, okay? And again, for bypass surgery, that's only left main and 3 vessel. So keep that in mind. The vast majority of patients in whom we're performing PCI or bypass with stable disease is for symptom relief and quality of life, and that's a good indication. Okay, let's talk a little bit about patients with diabetes mellitus. Again, a very important subset, as I illustrated this morning. These were very important data from the original Berry 1 trial that looked at 7-year outcomes, okay? So in this study, which was bypass surgery versus PTCA, mostly patients with 2-vessel disease, but a little bit of 3-vessel disease, you'll notice that for all patients, there was a slight, barely significant benefit in favor of bypass surgery. In patients without diabetes, the outcomes are exactly the same. So patients that did not have diabetes did well with bare metal stents and in comparison to bypass surgery. However, patients with diabetes, with treated diabetes, there was a 20% benefit in favor of bypass surgery. So this actually led to a clinical alert from the National Institutes of Health that went all over the country and was the first indication that bypass surgery may be clearly the preferred treatment for diabetes. And possibly it's due to this fact, that patients who've been bypassed, if they have a subsequent heart attack, STEMI or non-STEMI, they tend to do much better than the ones that have not had bypass surgery. And that could be the mechanism. Now, the follow-up study, which we also participated in, the Berry 2D study, was focused on diabetes mellitus and looked at a strategy of early revascularization versus intensive medical therapy, okay? And you'll notice there's no difference, either in mortality or death, MI, stroke. And then there was a second randomization to the TZD drugs, which I mentioned this morning, which are the insulin sensitizers. Now, everyone, including me, we all expected that maybe the mortality would be improved with these drugs because they were able to lower the hemoglobin A1C. But in fact, there was no difference, okay? So this was a completely negative study. And this is why, by the way, I find these new classes of diabetes medications that I talked about this morning so exciting. Because most of the recent big trials have been negative until these new classes of medications have become available. So for diabetes, clearly bypass surgery is favored over PCI, especially for multivessel disease. All right, but then what about drug-eluting stents, okay? Now, drug-eluting stents, you have to remember the reason they were invented is because of restenosis. So restenosis and the need for further procedures really has been the main difference between balloon angioplasty, bare metal stents, and bypass surgery. Who knows what's going on here? This is the baby Achilles being dipped into the river Styx. So restenosis was called the Achilles heel of angioplasty for many years. And it wasn't until these drugs were discovered and put on stents that we actually were able to make any inroads into restenosis. There were literally dozens and dozens of negative trials. So the first drug was rapamycin or sirolimus. This is a naturally occurring antibiotic that's produced by a fungus that was discovered on the Easter island of Rapa Nui, hence the name rapamycin. And rapamycin has been used for solid organ transplantation. We use it for heart transplantation, as you're probably aware, et cetera. But when you put it on a coronary stent, it reduces restenosis. The second drug was, and by the way, the second generation stents have derivatives of this first generation drug. The other one was Taxol, which is a tubulin inhibitor, also comes to us from nature, from the bark of the Pacific yew tree, Taxus brevifolia, hence the name Taxus stent. And this is how they work. They work really well in animal models. You can see the neo-intimal hyperplasia in the control stent, and in the drug-eluting stent, much less. So when these stents are put into humans, here's the effects that we have. No difference in mortality, okay? No difference in MI, but a reduction in redo rates and angiographic restenosis. So drug-eluting stents don't reduce their rates of death or MI, okay? Sometimes people think that they do, but they actually don't. What they do is they reduce restenosis. That's why they were invented in the first place. A couple of caveats with these drug-eluting stents. They take longer to heal, and I showed you some photomicrographs of a patient this morning. They take longer to heal, hence we need longer duration antiplatelet therapy. On the basis of this study from Dr. Soroy's group in Rotterdam, where 4 patients had late stent thromboses, the cardiovascular community decided to lengthen the antiplatelet duration to 1 year, and till now we're generally use 1 year. This may be shortening though, so stay tuned. Okay, what about that's drug-eluting stents. What about multivessel disease? There's been a lot of new data, important data in multivessel disease. Firstly, there were 5 trials that looked at bare metal stents versus bypass surgery. And bypass surgery actually was associated with much less restenosis or repeat revascularization, from about 20 down to less than 5%. But you notice the death and MI rates really weren't that different. And again, this applies in clinical trials only to patients eligible for both procedures. Now, another meta-analysis that looked at 10 trials, compared balloon angioplasty, bare metal stents to bypass surgery, and basically reiterated what we found before, is that in patients that have diabetes, who are these, there was a huge benefit in bypass surgery compared to PCI. The bypass patients still don't do that great, but they do better than the ones who've had PCI. So for multivessel disease, again, bypass surgery tends to be favored, particularly in the diabetic subset. I'll just skip through this slide. Now, all of you will also read many large registry analyses that are published in the literature, like this is an important one from the New York State Registry. And what this showed is a couple of things. It showed that 3-vessel disease with disease of the proximal LAD artery did better with bypass surgery than with stenting. But a couple of things I want to point out. When you read these registries, take a look at this. I went back in and recalculated the numbers, and what we found, you don't have to look at the numbers closely, but here's the important fact, is that 85% of all 3-vessel disease patients underwent bypass surgery. So therefore, everyone in New York State basically had reached a consensus that bypass surgery is preferred for those patients. So the other 15% that had PTCA actually had it because they were poor bypass candidates, or they refused surgery. So this selection bias is huge in these registry trials, registry studies. So what I would advise is that when you're reading the literature, keep in mind that registries are basically outcome studies. They're what you see is what you get, WYSIWYG, right? They're all comers. They're important for local quality control, but they can't tell you if treatment A is better than treatment B. If you want to know whether one treatment is better than another treatment, you really need to look at the randomized clinical trials. The problem with those is that sometimes generalizability is an issue. So let's think about randomized trials in multivessel coronary disease. And this is a critically important one, the SYNTAX trial. Here's the bottom line. The results of our trials show that bypass surgery, as compared with PCI, is associated with a lower risk of major adverse cardiac or cerebrovascular events at 1 year among patients with 3-vessel or left main disease. So remember, earlier I told you from the older trials, that left main and 3-vessel disease carries a class 1 indication for bypass surgery. This trial just reinforces that, okay? So this trial, the Syntax trial, reinforces that. An important contribution of the Syntax trial was a so-called Syntax score, which is a score that categorizes severity of coronary disease based on these anatomic characteristics. You will not have to know this for your board exams. But basically what this shows is that the worse the Syntax score, like for example, this is 19, there's a discrete lesion there, discrete lesion there, discrete lesion there. With the lower Syntax scores, patients treated with bypass surgery or drug-eluting stents did reasonably well. Both groups did reasonably well. But the worse the Syntax score, like this patient would have a Syntax of 30, okay, it's worse coronary disease, then pretty clearly these patients did better with bypass surgery in the long run. And if you have really high Syntax scores, like this one, a 53, then there was a huge benefit, right? So what these data are telling us is they're reinforcing what the original data did, is that the sicker the patient, the worse the disease, okay, the more they're going to benefit from bypass surgery. That's what these data are actually telling us. So the 2-year Syntax results, I like this interpretation by Dr. Peter Capitan, suggested that bypass remains a standard of care for patients with complex disease. However, PCI may be an acceptable alternative when treating patients with less complex disease. And I think that's a good, practical, common sense interpretation of the Syntax data. Now, what about the Freedom trial, which is a trial you've all heard about and will be on board exams? So this looked at multi-vessel revascularization in diabetes. Now remember, the data I've already shown you showed that bypass surgery is pretty clearly favored over PCI. And so this would be a typical, you've seen the slide already, a typical multi-vessel diabetic patient. And in the Freedom trial, again, patients treated with bypass surgery really did much better, okay? So I would just ask you to keep that in mind. And for any patients that you see on your board examinations where they ask you to recommend a revascularization treatment, if they're multivessel and diabetic, even with modern drug-eluting stents, bypass surgery is still favored, okay? Now, what about left main disease? Here things may be shifting a little bit. In the Syntax trial, in the right-hand panel, if you look at left main disease patients, you'll notice that patients treated with drug-eluting stents did well in comparison to those treated with bypass surgery. This does not mean that all patients with left main disease can undergo PCI. But those that have discrete lesions, it might be an option to consider if they're not diabetic. But most of our left main disease patients have calcified left mains, they have bifurcation disease, and those are not good for PCI right now. A couple of recent trials that were published, the Noble trial, 1,200 patients, stable coronary disease, again showing that patients treated surgically did better in terms of adverse event rates at 5 years, okay? So it kind of confirms bypass surgery is preferred for left main disease. But what about this one? This is the XL trial, 1,900 patients, low or intermediate risk Syntax scores, very little difference between bypass surgery and PCI rates. So again, for patients that have lower Syntax scores or not as severe coronary disease or not diabetic, have good LV function, they might be candidates for left main stenting if that's what the patient prefers. Now they asked me to talk about FFR. So here's a typical patient who has a bifurcation or trifurcation of the LAD with moderate lesions. Like the patient I showed you this morning, we sometimes have to make a decision on the table as to what to do. A very important adjunctive tool that we use now is FFR, or fractional flow reserve. We can pass a pressure wire through these lesions into the distal coronary artery. And so here you would see like a normal FFR. You measure the pressure, you give adenosine, and that tells you what, under maximal hyperemia, what the ratio is. So it's a real, those of you that work in cath labs, I'm sure know this, but if you don't work in cath labs, what you need to know, it's a real-time physiologic assessment of the hemodynamic significance of a lesion, okay? So the pressure is measured proximal and distal. We give adenosine, induce maximal hyperemia, and if the lesion is significant, what will happen is that the distal pressure will fall, and then the ratio will go down. And that means it's significant, you probably should treat it. This is the same slide I showed you this morning. It shows how when you cross the stenosis, this patient had a resting gradient. With adenosine, it went even lower to 0.3. Put a stent in, and then the FFR theoretically should revert to normal. So this approach is actually well validated, and I think we should be using it more often in cath labs. There are a couple of trials looking at clinical endpoints and clinical outcomes that support that assertion. The FAME trial showed that FFR-guided PCI, as compared to medical therapy, actually improved outcomes. So in other words, if they had medical therapy and you only treated the severe lesions, patients actually did well. So what about summary here in the last few minutes? So number one, I think remember for your board exams, for almost all patients with left main disease, bypass surgery is indicated. There may be a few that are low-risk patients with discrete lesions that drug-eluting stents may be adequate for. 3-vessel disease, similarly, bypass surgery is a class 1 indication, PCI only if low risk. 2-vessel, you could go either way. 1-vessel disease, which is actually about 70% of all the revascularizations we do, is best treated with PCI. Remember, low ejection fraction and diabetes always favor bypass, and use physiology and ischemia as your guides for decision making. So thank you.
All right, a lot of trials, very well summarized. Have a seat. Let's kind of go over this. So let's go back to this 67-year-old man with class 3 angina on medical therapy. Highly positive treadmill test, resolved after 5 minutes. CAS shows that calcified 90% mid-left anterior descending lesion. Okay, so let's keep on going with the questions here. Remember, we're going to ask if PCI is indicated for next prevention of acute myocardial infarction, prevention of heart failure, prolongation of life, or improvement of symptoms. Okay.
Great, all right. Well, let's talk about this one. So for a mid-LAD, all right, this is not a prognostically important lesion like proximal LAD or left main disease. So prolongation of life is usually not considered an indication for a mid-LAD PCI. However, as I've mentioned multiple times, the best indication we have is to make your patient feel better, improve their quality of life, improve their effort and exercise tolerance. So that would be the indication. If you look at the other ones, PCI does not prevent acute myocardial infarction. In fact, you may cause an acute myocardial infarction when you're doing the procedure as a complication. So keep in mind why you're doing what you're doing, okay?
Now, one of the people, this is a good question. If the guy's like diabetic, okay, doesn't feel any pain, has that treadmill and has an LAD mid-lesion, are you going to just leave it alone?
That's a good question. It's unknown what to do. This is why we're doing the ischemia trial. Yeah, the scientific answer is unknown. I think what you would actually do with the patient in front of you sort of depends. Yeah.
And the ischemia trial is kind of a randomized trial of looking at revascularization in patients with a load of ischemia, I think 15% or more of the myocardium.
It'll be a really, really important study.
Yeah, it'll be incredibly important to know what to do with these patients that you might not just relieve symptoms, but you might do something else on. But until then,
we don't know.
We have to say it's only for relief of symptoms.
Theoretically, the risk is that ischemia could cause sudden death.
Yes.
That's the theoretic risk.
Yeah. But we have no data to say we could prevent it. 65-year-old man presents with new onset angina. Comorbidities include type 2 diabetes, hypertension. He's got the 3-vessel disease, which is shown on the next slide, with a mild reduction in LV function. So the treatment of choice is And this is the angiogram that you've seen before.
And your interventionalist says these are discrete lesions, I can stent them in 30 minutes.
You did?
No, that's what they will say, right?
You're my interventionist, though.
I can stent those in 30 minutes.
Okay. So Dr. Rehal can stent those in 30 minutes. Okay, let's go to the question. Should you do medical therapy, multivessel PTCA, multivessel stenting, cabbage therapy? Depends on, well, like I said, Rehal's always comfortable and the level of the comfort of the surgeon.
Good job.
All right, they can clap.
So remember, for board examinations, there's tons of data suggesting bypass surgery provides better outcomes in the long run for your patients. And remember, all patients get medical therapy. It's really not an either or. So having medical therapy, and there's sort of the wrong thing to do because every patient needs to have good medical therapy.
Now, what about if the patient were not diabetic?
Then I think it's a different niche because then the interplay of risks and benefits are different. Those technically are sort of low-risk lesions we would consider. Mm-hmm. And some of the data that I showed you did emphasize that the long-term outcomes are the same for non-diabetics. So I think then you could do whatever the patients prefer.
So the history of diabetes actually makes a big difference, in pushing you to bypass.
Yeah. So remember, diabetes, as I've said, is a systemic disease. It causes a very aggressive proliferative atherosclerosis, it causes restenosis, and it causes thrombosis. So it's a different animal.
And there seems to be something magic about this Lima to LAD versus a PCI of a proximal LAD. Can you discuss that?
So the Lima grafts are associated with the best long-term patency of any treatment modality that we have, including drug-eluting stents. And there are data showing that if somebody has a Lima graft in place and everything else is occluded, they can still live.
Yeah.
And in fact, if these patients come back with a subsequent myocardial infarction, they tend to do much better.
Yeah. So that Lima, there's something magic about a Lima to a good-looking LAD. Yeah. And remember, if you stent the proximal LAD, especially in a diabetic, chances are the mid and the distal LAD are going to have their lesions that are going to go ahead and thrombose and occlude. So there's something about that Lima that we really, really like in these patients.
And interestingly, the Lima doesn't get atherosclerosis.
Right.
Right? So.
Right. What about a REMA?
So the REMA, it's a really good question, whether or not people should be doing bilateral. The problem with bilateral internal thoracic arteries in diabetic patients is it increases the risk for sternal wound infections and dehiscence and that sort of thing. So I think most of our surgical colleagues still favor doing a Lima and maybe a radial artery graft plus a vein graft in diabetic patients. But I don't see them doing a lot of bilaterals.
Yeah, and is a radial artery better than a vein graft?
Yeah, we think so. Okay. Yeah.
And there's some recent good data that says that arterial revascularization, even though it's a lot more difficult, is better than the vein grafts.
I think if you're getting a bypass surgery, I would ask your surgeon to do total arterial if possible.
Yeah. Okay, previously healthy 53-year-old man presents with angina. What are the key prognostic indicators? LV function, extent of coronary disease, degree of ischemia, or all of the above?
Excellent.
Good.
So let's talk about this. So it's important to recognize LV function is the most important prognostic indicator in all categories of heart disease.
Yep.
Ventricular arrhythmias, what's the most important prognostic indicator? LV function. Congenital heart disease, LV function, or systemic ventricular function. Yeah,
depending on
systemic ventricular function. Right, so in all heart diseases, LV function is the single most important prognostic indicator. Now in coronary disease, the other things that we look at are epicardial coronary disease. The worse the disease, the worse the prognosis, and amount of ischemia/angina, right? The more ischemia they have, again, as I showed you the data, the worse they're going to do. So if you put these things together, right, if you have all three, they're really high risk, and they need to be revascularized. If they have just one out of the three, mild symptoms, you can treat them medically pretty safely.
So give us your interpretation of the 10-year follow-up of the STITCH trial. Let's say the person has an ejection fraction of 30%, has angina, which is pretty well controlled. Would you revascularize that
You know,
patient?
I still think it's sort of unknown. If it takes 10 years to show a positive outcome, there's an issue there. The issue with the STITCH trial was this whole viability thing. So we thought that patients who had viability would benefit more from bypass surgery, but it actually went the other way.
Yeah.
And it could be that putting patients with multivessel disease, multiple occlusions, LV dysfunction, you put them on bypass, cardiopulmonary bypass, you just can't perfuse the distal vascular bed, and it could be causing myocyte damage. So I think it's sort of unknown, and we don't really use preservation of LV function as the only indicator for bypass
You don't
surgery.
operate for LV dysfunction itself.
No, we still don't do that.
Okay, so you want to talk about what you wanted to say here with this
Well, no,
exertional
yeah, I
angina?
think this was just showing that the stress images on the left show significant myocardial ischemia in the cross-sectional views that then fills in on the rest images later. So that in combination with severe epicardial coronary disease would indicate that this patient needs to have something done.
Question about the left main coronary artery stenting, which we're going more and more towards, especially if it's a discrete lesion. What about the dual antiplatelet agents, and how long, I mean, do you have to give it to them forever? Is it safe to ever stop them? I mean, if that left main occludes, they're dead. So what?
This is one of the practical problems with left main PCIs. We don't really know the answer to that question, right? If I had a left main stent, I'd stay on dual antiplatelet therapy forever, I think.
Yep.
Right? Because the consequences of making the wrong decision are catastrophic.
So in a person who might have a contraindication for dual antiplatelets, might not be
Bypass.
the right thing to do.
Exactly. Really important. And by the way, sooner or later, everyone develops a contraindication, right? Sooner or later, everyone's going to need, an ankle pinned or, a colonoscopy or, a biopsy or an operation. Sooner or later, everyone develops a contraindication to dual antiplatelet therapy.
And then finally talk about triple therapy with the warfarin, the DOACs, the aspirin, and the other antiplatelets.
Dangerous, never do it.
Don't you have to do it though? Okay,
So this is a misnomer. So what's going on here, folks, is that atrial fibrillation and coronary disease frequently coexist. So people look at this and say, well, we've got to give warfarin or potentially a DOAC for the atrial fibrillation, and we've got to give a dual antiplatelet therapy for our stent. So they end up giving all three. There's no safety data, none. So we tried to publish a paper, about 10 years ago. They kept getting rejected, and we gave up, showing that the incidence of severe life-threatening hemorrhage is like 20% per year. So most of the patients we see with AF and with CAD are elderly, 70s, 80s, sometimes 90s. I've personally lost patients with intracranial hemorrhage with all three, and I just never, ever do it.
So what do you do? I mean, you've got a patient, long-term anticoagulation for atrial fibrillation, comes in, needs a stent. Tell us what you do from the practical standpoint.
So from a practical standpoint, you try to minimize the duration of dual antiplatelet therapy. As I've mentioned, with a new generation of stents, you can go down to 3 months, and then you can switch them to warfarin plus a single antiplatelet therapy. So we typically will use Plavix in our practice. Plavix does not induce bleeding. It doesn't have the gastritis that the aspirin does. So it may actually be a little safer than aspirin. So we tend to use 75 of Plavix and low intensity warfarin therapy.
And then the DOACs with antiplatelet agents,
Well, it's unknown. It's really unknown.
And we'll have
some
randomized trials coming out with that in the future. But for now, the safest that we know of is warfarin and Plavix. Then.
Low intensity warfarin and Plavix, or a DOAC plus Plavix.
Okay.
But you can't really have a low intensity DOAC is the issue.
That's right.
Yeah.